Good afternoon, everybody. We're going to get our next session started. I have the pleasure of introducing Dr. Romo. Dr. Romo is an assistant professor of neurology and oncology at Johns Hopkins University School of Medicine. He's attending physician of Johns Hopkins Comprehensive Neurofibromatosis Center, and he's the director of the clinical research of the Neurofibromatosis Therapeutic Acceleration Program. Dr. Romo's research interests are in early phase clinical trials for the treatment of neurofibromas and gliomas. Welcome, Dr. Romo.
Thank you. Thank you for the invitation. Thank you for being here. And I'm sorry, how do I advance my slides? Big green button. There's not one here. There's nothing but a microphone. Oh, I see it. It's in here. Thank you. Perfect. Okay, cool. I don't have any financial conflicts to disclose, but I will be chatting about medications that are not approved by the FDA for the treatment of cutaneous neurofibromas. And I will be, another disclosure I didn't put up on this slide, there will be a lot of shameless plugs for my research and the research that I'm doing. So be prepared for that and be prepared to participate. So I'd like to make this not a talk or a lecture, but a conversation with everyone here because I want to learn as much as possible as well. And I outlined these goals for this conversation. One is to talk about the big picture about cutaneous neurofibromas. Then I know from chatting with some of you that you're interested in learning about treatment options. I wanted to talk to you about research. And lastly, leave a lot of time for questions so that we can chat about concerns you might have. And there are 3 questions that I put as polls on the Whova app. So if you want to start answering those questions, that'd be great. And I can take a look at the answers on my phone and we can discuss them together. So I don't have to tell this audience that NF1 comes with many manifestations, but today we're only focusing for this conversation on the cutaneous manifestations and more specifically on the cutaneous neurofibromas. So the way I formatted this talk is by answering questions that I've heard from my patients. Hopefully it answers your own questions, but we'll leave time for additional ones. So maybe a basic question would be, what are cutaneous neurofibromas? They are benign tumors, they're not cancerous, and they form from the sheath that protects the nerves. And so you see this image here of the peripheral nervous system. Everything you see in yellow is nerves, and you have a neuron there. The body of the neuron is the blue part. And then, I don't know if this pointer works, maybe. But everything you see that's pink would be Schwann cells that actually cover the axons of the nerve, those wires that help conduct electricity. And the cutaneous neurofibromas come from those yellow, not yellow, but the pink structures there, okay? When we remove them and we look at them under the microscope, they're made of Schwann cells, but they're also made of a bunch of other types of cells, including inflammatory cells, like some cells are called mast cells, some cells are macrophages. They play different roles in our immune system and they're there. So we think there's a component of inflammation that plays a part in this formation of cutaneous neurofibromas. But very importantly, there's a nerve, and that nerve also speaks to those other Schwann cells and maybe helps them grow. So we also have to think about that discussion that they're having, and we call that the microenvironment, how the cells talk to each other and make each other grow and proliferate, which is what we don't want. Are there more than one type of neurofibromas? And the answer is yes. We talk about neurofibromas, and this I think is very important when you're going to see your clinicians, your doctors, your providers, to talk about them in using the proper terms. Cutaneous neurofibromas are skin deep tumors, but there are also subcutaneous neurofibromas that are under the skin. And then there are deeper tumors that we call plexiform neurofibromas. And if those internal tumors are close to the spine, we call those paraspinal neurofibromas. When we look at them under the microscope, they all look very similar though. But mainly where they're located is what classifies them as cutaneous versus paraspinal versus plexiform versus subcutaneous. And then you'll hear some terms like diffuse neurofibromas or nodular neurofibromas. And when we say those things, we can refer to any of these types as diffuse or nodular. And diffuse just means that they infiltrate other tissues. They're not just a round, well-delineated structure. That would be a nodular tumor. And again, today we're going to be chatting specifically in this conversation about cutaneous neurofibromas. And then we further complicate things in medicine by talking about subtypes, but it helps us a little bit when we think about clinical trials and how to treat them if we subclassify them, because they are different. So here you have images about how we classify the cutaneous neurofibromas. So the nascent ones are ones that we actually cannot see with the naked eye, but we know they're there because we can use ultrasound, high frequency ultrasounds to see them under the skin, but you can actually not see them with your own eyes. The flat neurofibromas are the ones that are not raised at all, but they just look a different color. The skin is a little bit thinned. They might look a little bit purplish, a little bit reddish, but they're not raised. When they're raised, we call them sessile, and when they grow even higher than that, about 20 millimeters in size, which is less than an inch, we call those globular neurofibromas. Lastly, peduncular or pedunculated neurofibromas are the ones that are connected to the skin through a stalk. A couple of other questions that I've heard from our patients is, someone recommended that they be biopsied. Someone recommended that they take them off because maybe there's something else and maybe they're cancer. Very rarely do they need to be biopsied. In most cases, I would say you don't need a biopsy. And there is no risk or almost zero risk of a cancerous transformation from a cutaneous neurofibroma. So that's not one of the concerns we have when we see you in clinic. We're not thinking, oh, is this cutaneous neurofibroma changing into cancer? That's not true for all forms of neurofibroma. We know that the plexiform neurofibromas can be have that conversion into cancer, but not the cutaneous ones. Even when they look a little bit angry on the slides, they're still benign tumors. I do sometimes recommend them being biopsied when I'm not sure if someone has NF1. I just recently saw a patient that only had about 6 or 7 cafe au lait marks and just a couple of what they look could be neurofibromas, but nothing else. So in that case, I did send her to a dermatologist to have them biopsied, because if they were neurofibromas, in fact, then that would meet the criteria for NF1, but rarely do they need to be biopsied. And this is a question for you, and I've received some answers and it was very enlightening. How many people with NF1 will actually develop a neurofibroma? What do you guys think? So I have the answers here. Just one person said 2 to 5%, 9 people said 20 to 25, 11 people said 50%, but most of you think more than 95%, and that's actually the correct answer. Almost everyone with NF, unfortunately, will develop at least 1 or 2 cutaneous neurofibromas throughout their lifetime. I'm sorry. And if you want to ask questions or make comments as I'm chatting, I'm happy to be interrupted. That'd be great. Okay, so how do NFs, cutaneous neurofibromas, affect people with NF1? And again, you know this better than I do, but when we ask a bunch of patients, this is what we hear, that they do impact their quality of life. When I started seeing people with NF, I thought maybe pain is going to be the biggest complaint. Maybe pain is the worst thing for them, but that's actually not what we hear in most cases, but that there are visible signs of the disease, that I don't like going out, I can't wear the clothes I like to wear because people will know that I have NF and I'm embarrassed by them and I feel self-conscious about them. But they can certainly cause pain, itchiness. If they get irritated, they can bleed, as you all know. And of course, there are other conditions that come with having cutaneous neurofibromas, including anxiety and depression. So there have been studies that look specifically into the quality of life and how that's affected by cutaneous neurofibromas. And here you can see the white bars are asking about the emotional effect that they have in people with NF. And you can see almost half of the people that answer these questionnaires had some emotional problems related to their cutaneous neurofibromas. A lot of them had symptoms, but not all of them. And some of them were having problems even with their function. So despite being benign and not becoming cancerous, they clearly affect the quality of life in people with NF. And again, one of the main concerns was the visibility of them. And most people answered in most cases that the fact that they can be seen affects their emotion, that causes additional symptoms like anxiety and depression, and that affects their function, their ability to relate to others, to be intimate with others, to get a job. things like that. Another common question that I have is, will I get new ones over time? And studies about the natural history of how cutaneous neurofibromas form and change over time are lacking, but we're working on that. And the data that we do have suggests that, yes, people tend to have more neurofibromas as they grow older, and there are a couple of episodes in life where we think you're more prone to getting new cutaneous neurofibromas. In women, that would be when you're pregnant. Doesn't happen in every pregnancy. Even in the same person, you could be pregnant 2 or 3 times, and maybe they just grew in one of those pregnancies. Some women don't have any growth during pregnancy. And the other one would be during adolescence and puberty, so when you're in your early teens. This is another study that showed that there was a slow growth of the number of cutaneous neurofibromas. Maybe the numbers are too small at the bottom, but these are months going from 0 to 100 months, and the number of cutaneous neurofibromas, and the darker blue line in the middle is kind of the average of how those tumors grew in the population that they studied. So you can see that in almost all cases, but especially in the back, people tended to have more neurofibromas over time. And again, I've heard from patients, I've seen this, and studies have shown that some of those cutaneous neurofibromas are there and they can start growing spontaneously without any insults. And some are there, but they stay quiescent, or they stay stable over time. They don't change in size, they don't change in color, they just stay there. So why does that happen, that some stay stable for a long period of time and some start growing pretty quickly? Again, that natural history, we don't know and we don't fully understand, but we're working on that. And so if you'd like to help us understand that better, we have this study ongoing right now called the Natural History Study of Cutaneous Neurofibromas in People with NF1. And we are very ambitious and want to have at least 500 patients, people with NF1, join us in clinic at Hopkins, located in Baltimore, to have participate in this study. And I won't talk too much about this because I have a little video at the end to show you as well. Another question that I get, and I think someone asked in the chat box as well here, why do some people have a few cutaneous neurofibromas, but then there are others that have many cutaneous neurofibromas? Even within a family, maybe mom has NF and that she has 100 neurofibromas and the kids have 1 or 2. And again, that's not something that we fully understand, but there's another study that we're working on with Dr. Sarin, who gave a talk earlier looking into this specific question. But there's a huge variability on how severe, quote unquote, the number of cutaneous neurofibromas can be. As you can see in this photo, there's someone has maybe 2 or 3, and someone can have thousands of them. And they can also be severe in other ways or less severe in other ways, how visible they are. Sometimes they can be different colors, different sizes, different shapes. They can be large and diffuse, or they can be small and nodular. And so to help understand this question about why some people have more or less cutaneous neurofibromas, there's a booth outside looking into something called a GWAS study, or a genome-wide association study. And we're recruiting, that's even a more ambitious project, trying to recruit almost 1,200 people with NF1 that are age 40 or above and have at least 1 cutaneous neurofibroma. So if you're interested in participating, you can do this from the comfort of your own home, or you can step outside and we can help you get registered and participate in this study. There are some perks of participating. We can chat to you about those. Another thing that we can think about is, are all skin bumps that people with NF develop, are those all cutaneous neurofibromas, and should I not be worried about any of them? And the answer is no. Unfortunately, people with NF can develop the other things that look like bumps. And here are several examples. We have warts, we have lipomas, which are benign fatty tissue tumors. We have very common skin tags, which are called acrocordons. And there are different things that your dermatologist, your neuro-oncologist that specializes in NF1 can take a look at. And if there's something that is concerning, you can biopsy them to make that distinction between some of these conditions and actual cutaneous benign neurofibromas. So treatment options. So I like to think about treatment options, and when I chat with patients in clinic, I try to look at the big picture first and then try to dissect the treatment options to see if any of them work for them. Unfortunately, there's no standardized way of treating a cutaneous neurofibroma or a patient with NF1 in terms of their benign skin tumors. And to this date, as of now, the most effective treatment that we know of, unfortunately, is just to have surgery and have them removed. There have been studies looking at medications and other therapies that are being attempted, but how effective they are and what level of side effects they have has been very variable and somewhat disappointing. So there are some medical treatments, especially for the symptoms, including pain and itchiness, but not so many to actually shrink the tumors or prevent them from happening in the first place. And lastly, I talked to my patients about clinical trials they could participate in. So this is an algorithm that the community usually follows, but again, it's not standardized. So we have someone who has a cutaneous neurofibromas. One question we can ask is, are there symptoms associated with them or not? And a lot of the times, as we saw on one of those tables with the bars that I showed you, some people actually don't have symptoms for their cutaneous neurofibromas. I met someone yesterday who very eloquently said, I am in a stage where I don't give an F about my neurofibromas anymore. And I thought, that's excellent, good for you. So some people are really not bothered by their fibromas, and you don't need to have them removed or do anything about them, if that's the case. But if you do have symptoms, then another good question would be, how many of them are actually causing you symptoms? Is it just one or two and you can pinpoint exactly which ones they are, or are there many of them? But if there are less than 100 tumors that are really bothering you, then we can look at the size of the tumors and determine whether surgery is beneficial, and surgery is typically beneficial in the larger ones that are about an inch or more in size. You can have other types of quote unquote less aggressive surgery with a shaved biopsy, for example, for the ones that are smaller. And then there are different types of photocoagulation treatment, and I'll talk to you briefly about them as well, that can be considered, but only for the smaller tumors. If there are more than 100 tumors that you're bothered by and you want to treat them with some form of procedure, then you can think about lasers or electrodesiccation. And again, depending on the size, there are different types of lasers. One of them is Co2 laser, and I'll talk to you about photocoagulation with Yak lasers, and electrodesiccation, which uses radioablation. There are some places with plastic surgeons that treat people with many tumors in a single session, and they call them mega sessions. Typically, patients go under general anesthesia, and they have hundreds of tumors treated either by photocoagulation, or many of them get resected at the same time. That's not readily available, and not many plastic surgeons or general surgeons like to do this. The recovery is typically a little bit more difficult because, if you can imagine, removing hundreds of tumors creates a lot of pain, inflammation, swelling, the potential for infections. And again, it's one thing to recover from an infected neurofibroma, but if you have 5 or 6 that got infected in this 300 removal resection session, then it'd be complicated. So I don't know if a lot of places in the US that actually do these mega sessions, but there are plastic surgeons that are comfortable removing many of them in one session. And surgery is particularly better than the lasers and the electrodesiccation for sensitive areas. You usually don't want any laser close to your eye. And so, for example, if you have tumors in the eyelids, surgical resection by a plastic surgeon or an ophthalmologist that's skilled in this kind of surgery would be better. If there are neurofibromas in structures that are very important, so structures like the neck where we have a lot of blood vessels and nerves, again, you might consider doing them through surgical resection that is can be a little bit more controlled than laser or photocoagulation with lasers and electrodesiccation. Women have frequently neurofibromas in their nipples, so that is also something that's better taken care of with surgical resection rather than lasers and electrodesiccation. And like I said before, if your tumors are more than 2 centimeters in size, so about a quarter or more in size, then surgery might be better. So I've mentioned this electrodesiccation thing a lot of times already. And this machine that you see in the bottom right corner is called a hyfractor, and it's a machine that actually has a little tip that looks like a needle that's inserted into the neurofibromas. And what it does, it gets really warm and it evaporates all the water. So it causes dehydration of the cells that make up the neurofibromas, and that's how it gets rid of the tumor. And you can see here in this picture, and I'm not sure if that's projecting very well, but many tumors can be treated in different sessions. So this patient had hundreds of the tumors treated by electrodesiccation. It's an outpatient procedure. It can also be painful, but tends to be a little bit less painful than actual surgery. The problem with electrodesiccation is that you cannot treat large tumors, and that also you will probably be changing the neurofibroma for what we call a hypopigmented scar, meaning a scar that looks a little bit lighter in skin tone than your regular skin around it. And again, I'm not sure that you can see that very well. Maybe I should magnify those photos next time. CO2 laser, we've talked about, that's the machine. That's the actual CO2 laser, and it's used for many other skin conditions. So some dermatology clinics will have these tools available, not all of them. We don't have these at Hopkins at this point, but that's something that can also be used to treat the neurofibromas. And as you can see from this picture, you can also have scars that are a little bit lighter than their surrounding skin. And so sometimes people prefer that. Sometimes people are not very excited about switching the neurofibroma for a more visible scar. Another question I heard from someone yesterday who I was talking with was asking me, well, what's the rate of recurrence from this? If I do the treatments, what's the chance that it'll just go back? And there's very little information about this. Whatever little information we have cites about a 3 to 10% chance that they will come back. So they're generally pretty effective and generally pretty permanent. But again, we lack a lot of good scientific data to answer that question. This is the other laser, and if you can say that 3 times fast, then that'd be great. I can't, so I won't say it. But a Yak Laser also takes care of the small cutaneous neurofibromas by using thermal necrosis. So again, it gets really hot and burns all those cells and kills the neurofibromas. Not readily available, very expensive, and needs a qualified dermatologist or surgeon to take care of this. And lastly, pharmacologic therapy, so medications. So as I mentioned at the beginning, there's not only the cells that make up the tumor, but the inflammation around them. So the other white blood cells, the neutrophils, and macrophages, and mast cells that are in the tumor, and the chemicals or the proteins that are around them. So we call cytokines and prostaglandins. These are chemical signals that cells use to interact with each other that generate more inflammation. So someone in the chat also asked, what about ketotin? Is it effective? Can it be used? And there's very, very few data about that. There is a study with 10 patients. There's a slightly bigger study with 27 patients. And there's a case report of a single patient that took ketotin for 30 years since they were a kid. And reportedly, it did help maybe prevent some of the neurofibromas. That's difficult to assess. And in some cases, it helped with the itchiness because it helps control mast cells. And those mast cells secrete a compound called histamine that causes itchiness. So if you block that, maybe it could be helpful. We don't use this very often in clinic, but I know of some really bright physicians that do use it and think it's very beneficial. As a main side effect, it causes people to be drowsy. I think that's probably one of the rate limiting factors in using ketotin. And then there are other treatment options like imiquimod, which was used as a topical agent to try to kill the neurofibromas. Unfortunately, not very effective. Non-steroidal anti-inflammatory agents. Some people have tried to inject diclofenac, which is an NSAID, into the tumors directly. Also not very effective, painful. Some of the tumors actually grew after the injection, so we don't use that at all. Imatinib is a medication that was initially used for leukemias and can be used in cutaneous neurofibromas, but when it was used, it was actually not used primarily for that, but for the treatment of plexiform neurofibromas, and they were saying, well, we'll treat someone for their plexiform and see if it does anything for the cutaneous. So not a focused study about imatinib on cutaneous neurofibromas, and it really didn't seem to make a huge difference. Gabapentin is not treating the inflammation. Gabapentin is actually an anti-seizure medication if you Google that, but we use it a lot of the times to treat the pain associated with the cutaneous neurofibromas, and sometimes it can help with the itchiness as well. And it's a medication that's usually well tolerated, and if you're taking other medications, usually doesn't have a lot of interactions with the other ones. When we're talking about trying to target the actual cells that make up the tumor, the Schwann cells, the neoplastic component, there have been many studies, actually not too many, but there have been some studies, and I wish I could use the pointer, but trying to block the cascade of signals that happens within a cell to stop them from growing or happening in the first place. And unfortunately, none of them have been very effective. Some of them we actually don't have the results for yet. And they can have a lot of side effects, especially the ones that are taken by mouth. And so not great right now in terms of using what we call systemic treatments for cutaneous neurofibromas. So this is another question for you. When should I consider participating in a clinical trial? There are some options here. And again, if you could use your app, that'd be great. And I can look at the answers. You think maybe, yeah, I see some people answering. That's great. So A, when my healthcare provider talks to me about one, when everything else has failed to help me, when there is a guarantee that I will benefit from that intervention, I don't want to participate ever because of whatever reason you might have, or always, or whenever feasible. So I don't think there's a wrong or right answer for this question. If you are answering never because of something, that might be a very valid answer, right? But in most cases, in the people that I know and treat in clinic, the answer is almost always consider it in any way you can. And some of the studies I already mentioned actually have no side effects, and they're just helping us learn more about these tumors so that we can treat them better, right? And so there might be things you can do, like the GWAS study I mentioned. You don't have to travel to Baltimore or to Stanford to see, to participate and give us great information that can inspire better treatments. You can do that from your home and get a $25 gift card as well. Yeah, try to participate. For the natural history study, if you want to participate in that, that'd be great. And I'll talk to you more about the natural history study because I'm really passionate about that project. But one of the things that I wanted to talk to you about clinical trials as I was thinking about this is maybe some people don't know how to look for clinical trials. So I can spend an hour chatting about all the clinical trials that are out there right now and talk to you about who to talk to and what they're for and things like that. But rather, I want to spend some time talking to you about the resource that can help you find the clinical trials that interest you and then contact the people that are in charge of them to see if you can participate. So there's this great resource that we're very lucky to have called Clinicaltrialsgov, G-O-V. And if you're taking notes, I would take note about this. Clinicaltrials.gov is a website where you can look up clinical trials about almost anything. But if you type in the condition section there, neurofibromatosis type 1, and then I would type cutaneous neurofibromas, and to that you can say gliomas, optic pathway glioma, scoliosis, whatever you want to type. It'll spit a bunch of answers. Yeah, those are the places where you would enter that information. And I'll give you results about the treatments, not the treatments, but the clinical trials that are there. And you can use several filters. For example, there are a bunch of them that are closed and not recruiting, and they happened in the 80s. You don't want to learn about those necessarily, so you can exclude those from your list. And you can click the ones that are not yet recruiting, but because they're so new, or the ones that are actually recruiting and might be available to me at this time. So I would select those two. And then here in the status is where you can see, yes, this study is recruiting. That is the GWAS study on number 1 right there, that you can participate outside again. And there's some that are very, very new, so new that they're not yet recruiting, and some that are available, like the inflection study, NFX 179, and there's a table out there if you want to ask them questions. You have to be careful though, because this is not a perfect tool. And sometimes you'll see, for example, studies that have nothing to do with NF1. For example, in this case, this is NF2 and continuous manifestations of NF2. So if you don't have NF2, then this particular study might not be of as much interest to you as the others. And then once you click on one clinical study that you're interested, you will see the title of the study at the very top. In this case, evaluating genetic modifiers of cutaneous neurofibromas in adults with neurofibromatosis type 1, or the GWAS study. And I don't think I've mentioned this, but we're recruiting just outside. And also it will say who the sponsor is, which is in this case, Stanford University. Dr. Kavita Sarin is a PI for that study, and Hopkins, myself, Dr. Blakely, who's here, is also participating as well. And so you would read about that, and there's a lot of details. There's contact information there if you have questions. There's a study description. So what is this study about? How can it benefit me, or not benefit me, but benefit the community as a whole? Is it recruiting? When was this first posted? And the contact location, etc. Okay. So that's that. So I've mentioned this study several times, so I figure I'd just spend a minute talking about it. So we've talked about the question of why do some people have more cutaneous neurofibromas than others? We don't know. Can we identify individuals that might be more effective earlier so that we can maybe do something to prevent them? Not yet. Could we monitor neurofibromas? One of the more recurring things that I've heard in the last couple of days is I don't have access to a provider. My providers are hours away from me. So maybe could we monitor cutaneous neurofibromas using our cell phones, our smartphones, and taking photos of them? We don't know. So these are three questions that the field does not have a good answer for, but this study might help us answer those questions. So with your participation, we could potentially answer those questions in the future. So like I said, if you want to participate here, we can do that. If you want to go home, think about this, read more about it, do that. And whenever you're comfortable, go to nf1genetics.org and you can help us participate. And then lastly, the natural history study of cutaneous neurofibromas. There are a bunch of other questions that we don't have an answer for, and this study will hopefully try to help us answer those questions. And the main idea of the natural history study is that, no, that wasn't my last slide, sorry. We could go back to the one. Yep, thank you. So with your participation, maybe we can answer some of those questions and more importantly, inspire better treatments, identify the populations that need those treatments earlier and earlier so that we actually don't have to be chatting about cutaneous neurofibromas. I hope maybe 10 years from now, I can be standing here and saying cutaneous neurofibromas, that's not a thing in an F anymore.
The majority of people with neurofibromatosis type 1 develop at least one cutaneous neurofibroma, also known as CNF. While these are benign tumors, they can cause pain, itchiness, and disfigurement and affect a person's quality of life. And little is known about how they form and grow. A team of researchers at Johns Hopkins is studying the natural history of CNF. They want to better understand how CNF tumors develop and change over time. This research will give doctors information that in the future may help them identify people at risk of developing CNFs and provide early interventions. It will also help prioritize future research focused on improving quality of life for patients and explore new ways of monitoring CNF with 3D camera technology. We are inviting people of all ages diagnosed with NF1 to participate in this important research study. Participants under the age of 18 with parental consent are welcome. Participants will provide a saliva sample for genetic testing to identify their NF1 mutation. They will have a 3D whole body photo taken once a year for 5 years. This will generate a three-dimensional image to monitor changes in CNF over time. It does not use radiation and has no expected side effects. Participants will also answer annual surveys to monitor their NF1 and CNF symptoms and how they do or do not affect their quality of life. Participants may also choose to donate blood and CNF tissue samples for future NF1 research initiatives. The study is open to anyone with NF1 living in the United States. Annual visits for the research study will take place at the Johns Hopkins Outpatient Center in Baltimore, Maryland. There is no cost to you, and eligible travel and parking expenses may be reimbursed up to $700 per visit. In fact, you'll get a $50 gift card during your first visit for participating in the study. With your participation, we hope to understand how CNFs affect people with NF1 and use this information to inspire more research and provide better outcomes for all people living with NF1. For more information, please visit hopkinsmedicine.org/NFresearch or contact our clinical research nurse, Christina Allen, at callen96@jhu.edu or call 240-484-4412.
Thank you. So next year, CTF might give me the award for most shameless plugs, and I'd be fine with that. But I am really passionate about research, and I think there's no way we can make a difference in NF if we don't participate in research, and we want to hear from you about what are your priorities and how we can make research better for everyone. And with that, I'd like to thank you for your attention and take questions. And there's a couple of people that raised their hands on this side.
Hello. I got one about your shameless study. For the participants, do you exclude anybody? Like if someone's taking a medication or anything like that, like someone's taking like gabapentin, would they be excluded or?
That's a great question. For the natural histories, for the GWAS study, there's no exclusion except you have to be 40 or older and have at least one cutaneous neurofibroma.
Okay, how about the other one?
For the other one, you should not be taking medication for your cutaneous neurofibromas to make them smaller. But if you're taking gabapentin to help with the itchiness or pain, that would totally be fine.
Okay.
And if you want to have surgeries, that's fine. We don't preclude patients from having surgery and during participation. If you become pregnant, that's fine. If you change medications for something else, that's fine. Most people will be eligible for the natural history study.
Appreciate that info.
And I think there was someone else in the back with a question.
Hello, Dr. Romo. Thank you for your presentation. My name's Catherine, and I'm a genetic counselor here at Lurie Children's. And so I work mostly with the pediatric and young adult population, and we do have youngsters who ask about using laser and electrodesiccation, and I just didn't know if it was safe in that population or if it's only recommended for adults.
It's not approved by the FDA for this particular condition, but it is generally safe. And I'm not a dermatologist, so you don't want me doing those things on you, but it is usually safe. And there are some things that are we should be concerned about. So if you have a defibrillator, you maybe don't want to be using electrodesiccation a lot, or not, at least not close to implanted devices for treatments. But otherwise, it's generally safe to use.
Are any of the treatments that you detailed here, do they apply to subcutaneous tumors?
So surgical resection for sure applies to subcutaneous tumors. You can chat with both plastic surgeons and sometimes with neurosurgeons that specialize in peripheral nerve sheath tumors or peripheral nerve surgeries. The other treatment options, not so much. The topical creams would probably not penetrate enough into the skin to treat an actual subcutaneous neurofibroma. But yeah, there's studies that need to be done about how to treat those two better. Oh, okay.
I can ask them if you can't get to
That'd be
either.
perfect.
So, can someone be both on an oral drug treatment and topical gel treatment?
If you're part of a clinical study, so let's say you're participating in this inflection study, then there are some rules, and you would have to check with the study participating team to see if those medications are the ones that are, we call them contraindicated, not able to use. So for example, you wouldn't be able to use a steroid medication while you're on the inflection study. So you would have to talk to your team about which medications are allowed and which ones aren't. If you're using medications outside of a clinical study, you can, for example, for the treatment of pain and itch, you could use a topical lidocaine cream, for example, or a capsaicin cream, or some diclofenac cream, that thing that was injected that doesn't work, maybe can help with pain if you use it as topical treatments. And if you, for some reason, are on selumetinib or trametinib or one of the MEK inhibitors, there probably wouldn't be too many interactions, and you could potentially use both.
All right, next, at what age do cutaneous neurofibromas begin to develop? And is there a typical age when the production increases?
So part of what we're trying to answer with the natural history study is understanding that we don't have a lot of information, and especially we don't have a lot of information in people who are not Caucasian. So, and that's a huge missed opportunity on previous studies that we're trying to address. Be as diverse as possible in our recruitment for cutaneous neurofibroma studies. And we don't know, but in general, people tend to think that kids, very young kids, don't have many cutaneous neurofibromas. I think that's, most people will nod their heads. They weren't born with them, but they slowly increase over time, especially when they're 9 to 10, they start noticing the very first ones. Then by age 15, they have many more. And like I said, some women who become pregnant during pregnancy, they notice that they either get a little bit bigger or they increase in number too. But we need to identify those critical groups of people that are more at risk so that we can use these treatments better for them.
If a child is complaining of itchy skin on a daily basis, would you recommend the use of an antihistamine on a daily basis? If so, which one? And could there be a benefit in prevention of fibromas in the future?
So antihistamines could be tried, but they tend to be not very effective and come with a myriad of potential side effects. And I'm not a pediatrician, and so I can't really talk about my experience in kids using this, but there are pediatricians here that can chat with you maybe later about how they treat itchiness in peds. But most of the times I do not recommend a Benadryl type of medication, and we resort to other treatments like gabapentin.
The two studies that you mentioned, can you tell us a little bit about when those began and when you expect to have some of those results to report back?
That's a good question. Both of them began last year, first recruitment last year for both of them. We are on our second stage of the natural history study. The first stage recruited 32 patients, and the idea was to see, is this feasible? Can we do it or not? Are patients interested? Does the camera system that we use work? Because it's never been used for neurofibromatosis, but we're trying to reappropriate that to help our community. And the answer was yes, it works, it's feasible, it doesn't hurt. Our youngest patient is 1 year old, so we had to hold a little kid like this so we could take their picture. And our oldest is, I think, 76. And so it is feasible. And based on that information, we are now recruiting for the second part, and that's the ambitious part of recruiting another 470 patients. And a lot of them are here already, potentially. And what was the GWAS study also started last year. We have 576 people already enrolled, and we need close to another 700 people. Yeah, for the readouts. For the natural history study, we are monitoring our patients for 5 years. So at the time we stop recruiting the number 500, then 5 years from now, we'll start to get all the data that we need, and that'll take us time to analyze the information and then publish the results, and then we'll be happy to chat with you about what those results were. For GWAS, it might be a little bit earlier than that.
Next question. If a young child, like age 4, who does not yet have a cutaneous neurofibroma, can they participate in the study?
They can participate in the natural history study. Anyone with NF1 can participate in the study. You don't have to have cutaneous neurofibromas. For the GWAS study, you have to be 40 years of age or older, and you have to have at least one neurofibroma.
My son had 3 bothersome neurofibromas and had them surgically removed. He formed keloids, which were as bothersome as the neurofibromas. What other options does he have? Yeah,
that's a great question, and that's a very challenging case because keloid formation can be even more bothersome. The initial cutaneous neurofibromas, they can be more visible, they can be painful, they can be itchy, and be a worse outcome. Fortunately, that's not very common, and sometimes plastic surgeons will use different techniques and sometimes even inject steroids before the surgery or during the surgery so that they prevent as much as possible keloid formation. But in that particular case, maybe one of the other options would be feasible, and I would try maybe one on a small tumor and see what the results are in terms of healing, and otherwise participating in natural history studies to understand this better. Or there's a study that is no longer recruiting patients using selumetinib, oral selumetinib, to treat cutaneous neurofibromas, and there's a study that will open up. People are working on opening up a study with another MEK inhibitor to treat cutaneous neurofibromas at Hopkins and UT Southwestern in Dallas. And then there's the topical treatment options.
I think this was mentioned in the video, but if you want to touch on getting involved in this study, is there travel reimbursements availability? To just touch on that again.
Yeah, there is travel reimbursement. So if you bring us your airfare tickets, or if you want to pay for your hotel, if you don't have a family or friends in Baltimore, you can do that. It's up to $700 per patient per trip.
And then, do cutaneous tumors prevent wounds from healing? I have a wound on my head/scalp and it won't heal, and I think there's a tumor pushing from underneath it.
That might be referring to a subcutaneous or maybe a plexiform neurofibroma. So yes, cutaneous neurofibromas and subcutaneous neurofibromas, especially those that are plaque-like and diffuse, and I don't think I showed a good picture of those kinds of neurofibromas, can impair wound healing. And so when they're removed, ideally surgeons like to remove them enough so that they have unaffected skin or relatively normal skin when they close, because that's the best chance of healing. Sometimes if they're cut in the middle or there's a part of the neurofibromas, wound healing can be a problem. But that particular case sounds like maybe not a cutaneous and maybe a subcutaneous or a plexiform.
You also touched on this on your slides, but I'll have you do a little further. What are your thoughts on oral ketotin being used for cutaneous neurofibromas? And I hope I pronounced that right.
Yeah, okay. Yeah. So again, I don't know what the intent of using that medication is. If it's to treat the itchiness, maybe there might be some benefit. If the intention is to shrink the tumors, I unfortunately doubt that it's going to be helpful. There's very, very little information about ketotin. There's a single case report, one single patient that apparently benefited from that. Is that applicable to everyone? Probably not.
Mine's more of a comment with the electrodesiccation surgery. I just had mine done on May 26th, and I love the results. They did my face and my chest and my neck and my tummy. I'm still a little bit sore, but this is what I look like after, right after surgery.
I can't see that, Sheila, but you'll show me later.
Okay. But I was just saying, if you really are thinking about it, it may not be for everybody, but it really helps and they can take a lot off.
Exactly. A lot of tumors can be treated in a single session. It tends to be anecdotally less painful than surgery, because surgery requires suturing and more traumatic manipulation of the tumors.
I had a few stitches and I had a couple of staples because I had a couple of big ones that he took off.
Yeah, and tumors can bleed with electrodesiccation sometimes, and so the ones that are bleeding a lot, a stitch can help with this. And so, yeah, sometimes you do also need stitches.
I'm still a little sore on the belly area, but I think that's kind of normal and it hasn't been that long, so.
Yeah, another concern that we haven't talked about too much is insurance and how to cover the cost of these procedures. And unfortunately, a lot of the times insurance companies consider them to be cosmetic procedures and therefore not covered by whatever
I'm very lucky I got it covered.
Yeah, so I think from our part, I tend to specify that they're being removed or treated because of symptoms, and sometimes that helps with the insurance covering them. But psychological distress from the way they look, I think, is a perfect reason to have them removed too. There's another question here.
Connie.
So our son is your patient, as you may know, and he recently had some cutaneous neurofibromas removed surgically and donated those to the Biobank. Can you comment on that for others?
Yes. So, and this was a question I was asked earlier in one of the sessions. Are there biorepositories or biobanks where we're storing samples, whether it be blood, cutaneous neurofibromas, brain tumor samples, whatever, plexiform neurofibromas? And there are several. CTF has one, and Annette answered that question. There's another one at Johns Hopkins, and we're collecting any kind of tissue from people with neurofibromatosis, whether it be blood, cutaneous neurofibromas, plexiforms, brain tumors, pheochromocytes, you name it. Whatever you want to donate to the biorepository, we'll take. And there's another one in Paris. The reason for doing those biobanks is really important, and also something that I get really excited about. So you may know of PSA, something we check in blood for guys to check for prostate cancer, right? That's called a biomarker. So we do a blood stick and we get a little bit of blood and send it to the lab to see Cologuard. You might have seen ads on TV. It's a they check your stool to check for colon cancer. That's another form of biomarker, right? But we don't have that for NF. We don't have a biomarker that will easily tell us about whether something is happening that we should be concerned about. And typically when we talk about that, we talk about the plexiforms, for example, converting into cancer, or people developing a brain tumor. And so biorepositories are helpful for that kind of research to develop biomarkers. They're also helpful to our understanding of the biology of how tumors form. If you remember, I spoke about some chemicals that cells use to communicate among each other's, prostaglandins, interleukins, things like that, and the microenvironment. Those are all questions that can potentially be answered by using tissue samples from patients. And so donating tissue for biorepository and future research is very important. And if you're having a neurofibroma removed just because it's itching or painful, or you don't like the way it looks, you might as well donate a portion of that tissue to one of the biorepositories and help research along the way. So thank you for asking that question. There's another question on that side, and someone maybe here too.
How do we donate blood to one of the banks? Do we just ask our physician, or?
That's a good question. I'm not sure about the CTF biorepository. So maybe if someone from CTF knows the answer to that question, that'd be great. For the biorepository at Hopkins, you have to give a consent to the tissue being donated. So we would chat with you over the phone or ideally in person about why we're collecting that tissue, how we're gonna take care of the tissue, how are we gonna protect your identity as much as possible. And then you would sign that consent form and we would collect the tissue and process it in the lab. So in most cases right now for Hopkins is people who come to Hopkins for some form of treatment. And I'm not sure if someone raised their hand on this side. Maybe not.
I think we're close to time. Almost
Yeah.
2 o'clock, so
1 minute to spare.
1 minute to spare.
Thank you so much for your time. Thank you for your attention, and I'll be around. Thank you.